Hello, this video is about how to do a mental state examination or an MSE. These are really easy to do once you get your head around them, so we'll go through them once. If you do have any questions or comments, please leave them for me and I'll try my best to answer them for you. MSEs are a big favourite with medical schools and examiners because they're quite contained. You can do them in about 8 to 10 minutes. So what is an MSE all about? So an MSE, a mental state examination, is a set of structured observations. So the point of an MSE is allow us to kind of codify our observations into a piece of writing or a verbal summary about how that patient is presenting at that time. So it will help us with our diagnosis because it helps us think about exactly what we've seen. It's also it's really good for monitoring progress, and this is what I've seen working with inpatients, is that you might have a patient who's got psychosis, and when you see them on Monday, they have completely no insight into some of their delusional perceptions and how they're delusional. But by Friday, you might find that actually they are starting to get some insight. So they can be really useful tools for monitoring a patient's progress. They're also good for communication with colleagues because so much of what we do as medical students and junior doctors is just to be able to pick up pathology, which we then take to our seniors who develop the management plan and are really in charge of that care. So the most important skill, I think, as a junior doctor is to be able to pick up what's wrong with that patient. And really that's what we're doing in an MSE. We're just telling our superior, or we're telling our colleagues what we noticed about that patient at that time. So how do we do it? So it's a set of observations. It's not really a set of formal questions. You would usually do it alongside taking your full psychiatric history. You can do an MSE without a psychiatric history, but some of the questions will overlap, so it just makes sense to do the two together. If you've known a patient for a while and it's a follow-up MSE, it might be that you can just do a short conversation that's very focused towards certain questions rather than having to do a full history. So what you're going to do is you're going to observe specific categories, and these are appearance, behaviour, mood, affect, speech, thoughts, which is broken down into content and form, perceptions, insight, cognition, and judgment. We're going to go through what each of those are now. So the first thing you need to comment on is, what does that patient look like? And that's really simple things. We're picking these things up all the time whenever we meet anyone. An MSE is just asking us to kind of write that down and think about how exactly does that patient look. Is the patient well kempt? Have they come in and they don't look like they've washed for a while? Do they look like they're not eating? Is their hair brushed? You know, if this is a patient you've been seeing for a while as an outpatient and all of a sudden this patient looks very dishevelled, that's unusual. That's something that's really important, that you almost feel bad picking that up and writing about it, but it's really important. Are they dressed appropriately? So you'll often see with mania that patients are dressed inappropriately. So it might be the middle of winter and they're wearing a very small skirt, no coat, really high strappy shoes, and it just looks inappropriate for the situation and the setting and the season. So think about the season, think about the setting. So are you in a doctor's surgery and they're dressed in a way that's very unusual for that setting? Think about that, write that down. In addition, are you seeing self-harm scars? All of these things are kind of important for really getting a picture of how that patient looks. Behaviour, this is a really big category sometimes because you want to note down everything about that patient's behaviour, which sometimes is not very much. Sometimes you might just answer the basic things, but if the patient's behaviour is a bit odd, then you really want to write down exactly what you've seen and why it was odd. The things that we want to check off in behaviour first off are things like, can the patient make eye contact with you? Are they able to maintain what's a normal level of eye contact? Because obviously we all do look away when we talk to people anyway, but are they staring? Do they not stop staring? Or are they not able to make eye contact with you at all? In terms of psychomotor activity, are they moving really fast? Are they speaking really fast? Or are they very slow? Those things will point you towards very different pathologies. So with something like a psychotic depression, you might see psychomotor retardation, which is where patients are moving very slowly. Or in mania, you might see that that person is moving very quickly. Facial expression, again, are they happy? Are they sad? How is their body language? Are they curled up? Are their arms crossed? All of that is really important. Note down everything. In terms of level of arousal, do they seem very tired? Are they very sleepy? Or are they really alert? Do they seem very awake? And are they able to sustain a rapport with you? So I work in a child psychiatry unit, and I do a lot of my MSEs when I'm doing ward round. A lot of the young people will not be able to sustain a rapport at all. They might not respond to any of the questions. It's important to note that. So a lot of people get confused as to the difference between mood and affect. Mood is someone's inner feelings, and it needs to be sustained. It's not really about how that mood is right at that second. It's more to do with how it's been over a specific period. And you want to log both a subjective and an objective view of mood. So ask the patient, how do you feel? You want to find out both subjective and objective mood. Objective is how you view the patient's mood. Subjective is how the patient says their mood is. So you would ask the patient, how are you feeling? How's your mood been? And the patient might say, I'm really happy. Your observation might be this patient's not happy at all. Maybe their body language is very hunched over. They look very sad. You have your subjective view that they're happy, your objective view that their mood is low, and then you can note that mood is incongruous. It doesn't really match with your findings. Or if the patient says they're low and you think that they're low, that would be a congruous mood. Euthymic means normal, so you can also log that. Affect is also kind of about the patient's mood, but it's more the outer manifestation of mood. So it's more similar to your objective view of mood. How does that patient's mood impact on how they are presenting to you? So if someone's very low, if their mood is very low, you might find that their face just doesn't move. They're very flat, they're very withdrawn, and we call that flat. If the patient is a bit flat but not completely flat, there is some sort of reaction there, we call that blunted. And if the patient is kind of reacting, they might seem very low, but they'll make a joke and they'll laugh at that joke, we would say that that is reactive. So the patient might have congruous low mood, but might have a reactive affect, and that tells us a lot about where that patient is. If you had a patient with congruous low mood and flat affect, you would think this patient is, we're really concerned about this patient, because you can really see that affect has been affected. Speech. So speech is a really interesting one. First things to note are, is that patient responding to you? So are you in a conversation where there is spontaneous speech? That means that patient is offering you speech without necessarily being prompted. Otherwise, you might say that the patient will respond but needs to be prompted, so they're only responding to your questions, or perhaps your patient is not responding to you at all. If you're in a consultation and your patient won't speak to you, it's very difficult to do the speech part of your assessment, because you can't comment on what's not there, other than to say, you can say to your examiner, it's difficult to comment on speech because I've only had non-verbal communication from this patient. But that's enough, because you're covering the head, you've covered in the headline, you're talking about the fact that there is no speech. If there is speech, we can comment on the volume. So if it's quiet, there's low volume speech. Rate is important for things like mania. So are they talking really, really quickly? That would make you think of something like hypomania or mania. And then you can comment on the rhythm as well, kind of whether it's monotonous or not. I think a lot of medical students and junior doctors worry the most about the MSE in terms of thought form and thought content, because there's quite a lot of meaty psychiatric terms that you need to know for a thought form, so certainly. So what a thought form is considering is there a formal thought disorder? So the kind of things that you can comment on are things like circumstantial talking. So this is where you might ask a question and they go all around the houses with their answer. You don't ever really reach a proper answer, or you might have some tangential thinking kind of go off on down a line that you weren't really expecting. You might have something called flight of ideas. So this is associated with mania or hypomania, and the patient is moving very quickly down topics which might rhyme, there might be puns. You should be able to see as the observer that there is some sort of connection between the topics that they're moving through. So it won't be a normal conversation where you move through topics as we do in a normal discourse. They will move very quickly, but you should be able to see a link between how they got from there to there. Opposed to that is something we would call loosening of associations, or night smooth thinking, or even derailment. And this is more associated with schizophrenia. And this is where loosening associations is kind of the best way of thinking about it, because that's exactly what's happening. Instead of being able to see how the patients got from A to B, you just can't understand how they got from one to the other. There isn't really a connection between the thing they just said and the next thing they say. The way to think about it is flight of ideas is about quickly moving through topics, and that fits in with mania because obviously everything's sped up. Loosening of associations is more associated with kind of the confusion and the things that you might see in schizophrenia where things are a bit more jumbled. You can also get something called clanging, which is to do with like rhymes. You'll get a lot of rhyming that doesn't really make sense, or neologisms, which is where patients are inventing their own words or slang. You can also comment in thought form about pressure or poverty of speech. In mania, for example, you'll get a pressured speech where the patients are talking very quickly. Poverty of speech you might see in depression. So an example of a formal thought disorder, this is clanging. So you get this in mania. Here's an example that we've got from a song by Justin Furstenfeld. And what we have here is: imagine the worst, systematic, sympathetic, quite pathetic, apologetic, paramedic, your heart is prosthetic. So we can see that there is a connection. They're all rhyming, but they don't really make sense. It's not coherent. We can't really link pathetic and paramedic. It just doesn't work. So that's the sort of thing that you might see in bipolar disorder. It's quite rare. Thought content is about people's beliefs and what they are thinking at that moment. So one of the things you might comment on is overvalued ideas. Overvalued ideas are quite common because the classic example is with anorexics will have overvalued ideas around body weight, and it means what it says on the tin. It's an idea that means more to them than it should to us. So probably most people think that their body could be better, that they could lose weight, but most of us don't value that idea to the extremes like people with an eating disorder do. At this point, if you are this is where you would kind of feed into your psychiatric history, where you would ask someone, have you ever thought about harming yourself, harming others? Think about what's the content of their thoughts. Are they thinking about harming themselves? You might also pick up here obsessional thoughts. I think the key to this one is to really dive into what's going on in the patient's mind at that point. What are they thinking about? And then work out whether that's an obsession or there's any thought of harm to themselves. So you could ask them, do you have any ideas that you feel others don't share? You're trying to pick up here, is there anything that they might think that other people have said to them, this idea, it just doesn't make sense, and they cling to that and they think, well, actually no, it does make sense to me. You could just go with a very broad, what have you been thinking about lately, which is probably what I would ask if I were doing an MSE without any form of psychiatric history. What have you been thinking about? It's a nice open question, and hopefully the patient will tell you what's on their mind, which will help you to fill in this one. So this also comes under thought. So thought withdrawal, thought broadcast, and thought insertion they're vanishingly rare, but it's one of those things that you do need to mention for your MSE. Thought withdrawal is where the person will think that someone's taking their thoughts away. Thought broadcast, someone's listening to their thoughts. Someone somewhere is able to hear what they are thinking. And thought insertion is where someone somewhere is putting thoughts into the patient's head. Obviously, these tend to be associated with a paranoid delusion. They will fit in most likely with that paranoid delusion. It's good just to ask about them when you take your history. And you could say, sometimes when people feel like you do, they think that someone is taking their thoughts away. Have you ever experienced this? Or you could say, have you ever felt that someone's listening in or able to listen into your thoughts? Have you ever thought that someone's putting any thoughts into your head, or are they your own thoughts? Probably the patient will say no, but it's good that you've asked. So perceptions, again, I think this can be confusing for people who are new to the MSE, just kind of grasping in your head the difference between a delusion, a hallucination, a pseudo-hallucination, and an illusion. So a delusion is a fixed, firm belief in the face of kind of evidence to the contrary, which doesn't fit in with their cultural belief. So that belief in a delusion, that belief is unshakable. You will not be able to shake them from it. And it has to be outside of what their culture would consider to be normal, because obviously you have to count for people's religious beliefs. A hallucination is a sensory perception without stimulus, and the patient will believe that this is real. That's the difference between pseudo-hallucination and a hallucination. In a pseudo-hallucination, the patient knows that that hallucination was not real. They still saw it, they still experienced it, but they know that it's not real. And an illusion is where there is a real stimulus. So there will be some sort of stimulus, but they will misinterpret it. So they might see a shadow and think that it was a man at the window. That would be an illusion. A hallucination occurs without stimulus. So the patient is just in a room and then they would experience something without that stimulus. Cognition is one that I always, in practice, I will tend to just say that the patient is orientated to time, place and person. You should be doing an MSE, or in an exam you should be offering an MSE. The likelihood is that your examiner won't expect you to do an MSE because you're time limited, but you could offer one. Otherwise you can comment on whether the patient is alert, are they drowsy, kind of what's their state. And then you can ask them, do you know where you are? Do you know what day it is? Do you know what time it is? Where are we? Who am I? Who are you? Just a couple of questions just to make sure they're orientated to time, place and person. Insight is really important. So we're trying to work out what the patient understands about their condition. If you were in a GP surgery and you saw someone with depression, you might say to them, what do you understand about your illness? And they would say, well, I think I've probably got depression, I'm feeling really low. And that patient would go on to explain to you that they know they have depression, they've had it for a long time, they still feel that they have it. That person has insight. They're able to talk to you about their condition. They know that it's there. They know that it's impacting your life. With something like psychosis, you might find that your patient has no insight into the fact that they're ill. So especially where you've got delusions, obviously they're fixed, firm beliefs. That patient, by the very nature of it, will believe that they're not ill and you're wrong, and whatever the nature of their delusion is all correct. So they will have no insight into their condition. Insight's really important to log because you can see it change week to week, month to month, as the patient gets better or gets worse. So I had a patient who came in with a drug-induced psychosis, and when he first came in, he had absolutely no insight at all. He would talk about his particular delusion and he would say, absolutely this happened, and I knew that it happened. And then a few days later, as obviously we kept him off the drugs, he would say, I totally believed at the time that this was real. I don't understand now why I thought this was real. So it's been a very big change in his insight in those few days. If you want to ask questions about insight, you could say to the patient, tell me about your illness. What do you understand about your illness? The patient might say, I don't have an illness. The doctor say, I've got an illness, but I don't. Or the patient might say, I understand that I'm ill and I want to get better. So you can have full insight, which would be the patient understands that they're completely ill. They're on board with everything. You might have completely impaired insight, which is where the patient's got no insight at all. Or you might have partial insight, where the patient is on board with some of the ideas that the medical team have about the patient being ill, but might not wholly accept all of those ideas. Judgment is about when assessing the patient's judgment. It very much does what it says on the tin. So you could ask things like, if you could smell smoke at home, what would you do? So you're just trying to assess whether that patient is safe to be at home, really. Or is that patient going to take their medications? That's important to know. You need to summarise your MSE. The most important thing is to pick the most salient points from that history. So start off and say, I've just seen Carl. He's a 25-year-old male who has presented to us today with a history of depression. Today I noticed that Carl was appropriately dressed for the season. He was able to sustain rapport, he made eye contact, etc., etc. Go all the way through, but make sure that you pick out the points that are most relevant. You can mention important negatives as well. So if that patient's come in with a history of mania and you've noticed that they don't have any symptoms of mania, so there's no pressured speech, there's no psychomotor agitation, you could mention that, because that's important to the examination as well. Things that aren't there as much as things that are there. As a general exam tip for medical school examinations, I tend to use headings to direct the examiner, because examiners are only human, and you've been watching this video now for 20 odd minutes. At some points you've probably zoned out. Examiners are only human. They are going to do the same things. So I will always use headings as I go through my summary. So in terms of appearance, I noticed that the patient was. In terms of behaviour, I noticed that the patient was. When I examined the patient's speech, I noticed that. Thought process was. So you're constantly directing the examiner to the fact that you've done a full MSE. I've done appearance, I've done behaviour, I've done thought, I've done mood, I've done affect, etc., etc. So in terms of moving through your exam, just make sure that you mention something from each section. If you're scrabbling about, you can't really remember, because exams make us all nervous. Just try and make sure before you go into that exam you know those categories inside out, every single one of them. Cover something from each section, because you're going to get a point somewhere. Try and think of the main points from each of those sections and just try and pull it out, at least one or two of them. And make sure you don't forget to do all of those things that you should do when you sit a medical examination. Introduce yourself, explain the point of your consultation to the patient. We're just going to have a chat, if that's okay, about how you've been, and then I'm going to talk to my examiner, if that's okay. Thank the patient at the end. Examiners love that. Be mindful of your time. You might want to offer a full history and things like an MSE or a mocker, but probably you won't have time to do that. Your station will probably be 8 or 10 minutes and you're not going to have time to do an MSE and a full psychiatric history in that time. But sometimes it's good to offer, or say at the end of your MSE, I would like to complement this MSE by doing a full psychiatric history and reviewing the patient's notes. Just makes the examiner think that you understand what you would do in a real hospital setting, which is to go and do a full workup for that patient. Always read the instructions of that station carefully. I know so many people who have made mistakes where they get nervous, they're so focused on going into that station that they don't read the instructions properly, and it might be that you only need to do an MSE and people try and do a full psychiatric history. Just be mindful of what you're being asked to do. That's everything from me. I hope this video is helpful. Please subscribe if you'd like to. Thank you very much.